The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Welcome back to Thal Pals, the Alpha Beta Revolution. I'm NinaMaria Badalamenti here with my co-host, Dr. Kevin Kuo. If you caught our last episode, we started our myth-busting series, breaking down the most common myths about thalassemia. So we had a lot to cover. This will be part 2 of our 2-part series. And today we're picking up right where we left off with more true or false statements, insights, and perspectives from both the patient and doctor side.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, patients, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on hemolytic and acquired anemias, including sickle cell disease, pyruvate kinase or PK deficiency, and thalassemia. To learn more, visit agios.com. That's agios.com.
All right, on to the next question. People with alpha and beta thalassemia are at risk of developing complications regardless of whether they receive regular transfusions. True or false? The answer here is true. And this is a good myth to bust because traditionally we tend to think about people with alpha thalassemia, particularly those with hemoglobin H disease, tends to not develop any complications or very little complications. And for many decades now, I feel that there's a huge population that's been neglected. First, the non-transfusion dependent thalassemics, but also specifically the hemoglobin H patients. And again, from publications by my very dear colleague, Professor Khalid Masalam, he has shown that the risk of developing complications as well as the number of complications is directly related to the hemoglobin. This tells you that thalassemia, regardless of the genotype or regardless of whether someone's receiving transfusions or not, does cause complications. And more importantly, is that different people experience different types of complications. So not everybody uniformly experiences just one set of complications. So it's important to work with your healthcare teams to monitor these conditions and monitor the complication so that we can prevent them from getting worse. Because the last thing we want is, for example, an extramedullary hematopoiesis, which is basically these extra growths that are near the spine that essentially are making extra blood for you. You don't want them to grow too big because if they grow too big, they can push against the spine and cause paralysis and all those things. That's not, you don't want to go into that direction. So this is why it's important to always follow up with your healthcare team and to get monitored regularly.
Yeah, I think that's a big emphasis there for everyone, and especially including our alpha thal friends, because again, a big myth that we need to be focusing on a little more. And I think it's good to make sure we're covering understanding all the different types of thalassemia, which I wanted to ask, do the complications of alpha thalassemia resemble the same as beta, or do they look different? I know you touched a little bit and said everyone is a little different, but are they the same types of complications or something else to completely look out for?
I think that between alpha and beta, there are many complications that are shared, and in fact, we do see them. I think the rate of complications may be a little different, but certainly the types of complications are quite universal. Great question. So, another one from me, 7 grams per deciliter of hemoglobin is the threshold in which below it, the risk of thalassemic complications begin to rise. True or false? So that's actually false. And I would say that right now I'm busting the myth more for the doctors and the providers than the patients. Because first of all, NinaMaria, I'm very confident that patients know that's completely false.
We feel it at least.
Exactly. If you feel it, it's there. And then The next question then comes is there a threshold? If you say 7 is not the right threshold, then what is the threshold? Studies have shown that the risk of complication starts to increase when the hemoglobin is below 10 grams per deciliter. And then you ask me, what about 6, what about 8, 8.5, 9? That's where you have an increase in complications. It doesn't matter whether you're lower. As I've mentioned previously from my dear colleagues' studies, that the complications do rise in a sort of semi-proportionate fashion with the severity of the anemia. So I think it's important to recognize that the traditional, quote unquote, traditional threshold, we don't need to transfuse anyone if the hemoglobin is 7 or higher than that's completely false. We really should be looking at the symptomatology and the complication that our patients have, and to direct the use of transfusion towards that.
Absolutely. I think, like you pointed out in the beginning, it's about how we're feeling. And like you said, patients, we can tell when we're not 10, that's for sure. We can tell the difference between 7 and 10. It's a big difference. And I think too, we're learning and we're growing, and it's important to keep up with those studies as we learn and grow and really treat them as tools. I think especially for our non-transfusion dependent friends, they might be sitting at they're very probably sitting at something under 10. So I think it's important to make sure our doctors are focused in on that as well.
I think that the continuing theme, right, in our podcast has always been, don't just look at one single value, don't just look at one single thing. Look at the whole. You have to consider the entire person as a whole when you're treating someone.
And have a conversation with them. Invite the patient into the treatment plan.
Yeah. As patients, please do speak up, right? This is your chance to tell the doctors how you feel.
I say it probably in almost every episode, but you are your best doctor. You have to be your own advocate, and you know yourself better than anyone. So it's up to you to be advocating for yourself, communicating how you feel, and be a part of the conversation.
Completely.
All right. Ready for the next one?
Absolutely.
Okay. Physical activity is encouraged in people living with thalassemia. True or false? So this one is true. I think sometimes there's maybe some confusion or uncertainty around physical activity because of the symptoms that we feel, often look fatigued, tired, things of that sort. And I think the key in this one is that it's a range, right? Some of us can maybe run a 5K. Some of us, maybe we want to just do a walk. But I think that the important part is physical activity is healthy for everyone. It might look different for everyone, but moving your body is part of our makeup. It's important for anyone and everyone, no matter what that looks like for you. So find something that you like. I'll be the first to admit, I don't enjoy working out. I can do it. My body can do it. I don't like it, but I find ways to trick myself. I find ways to go on fun walks, or I like dancing, so I'll resort to that. But I think this one is really important because I think it's a myth out there that we can't move, we can't be physically active. And I think more than we can't, we should.
You know, NinaMaria, I couldn't have put it better myself. Next time when my patients ask me that question, I'm just going to play back this segment.
Sounds good to me. Hey, guys. Do you have anything to add to that one?
You know what? I feel that with physical activity, you do have to push yourself a little bit, right? Don't push yourself to the extreme. And I know I'm giving general motherhood advice here, but it's true, right? Everything in moderation. So you want to do some activity at least. You don't want to, and you know what? I think establishing a routine is the best way, right? Because often the question is, how do I know that I'm pushing myself too much? Like, I think that's always the question that people have in their mind. And by establishing a routine, then you know that what you're capable of and what you're not capable of. And by doing more, it's like practicing, right? Whatever we do, we excel at doing something because we practice with it. And exercise is the same thing. As we do more, we practice more, then we're able to gauge our body. And that's the best way of knowing what your capacity is and how far you can push yourself.
Absolutely. I think routine is really good for a lot of things, that being one of them. I think another thing that I tell myself is just listen to my body. Like, your body will tell you how it's feeling. If you start not feeling right, not feeling well, then that's like a signal to you. Push yourself. You know the difference. You know your body. So you know when it's trying to tell me something, then you can gauge better where you're at.
Absolutely.
Next one. If I have thalassemia, my children will automatically inherit it. Okay, this one is false. I think it's really important. I think it's a somewhat common misconception, and that probably comes from the fact that your children will get the trait, but they won't necessarily have thalassemia, and that all depends on your partner and your genetics. And correct me if I'm wrong, but your child will have a 50% chance. No, it will have a 100% chance of getting trait, but 0% as long as your partner does not have trait.
That is correct.
Okay.
That's exactly right.
So I think it's good to just be in the know. I think there's genetic testing out there, which is really wonderful now that we have that. And you can have your partner tested, and then you at least know what you're getting yourself into and what the chances are that your child would inherit thalassemia. And then you can make your decisions from there. But no, your child will not have thalassemia just because you have thalassemia.
That's exactly right, NinaMaria. Again, I couldn't have said it better. I think the only thing I probably want to add is that genes comes in pairs, not Levi's jeans.
They also come in pairs.
So genes comes in pairs, and what happens is it takes two to tango for thalassemia, meaning that you need to have both of your thalassemia genes being affected in order for you to have thalassemia. So you can imagine, just like you said, if, say, someone has thalassemia, but then your partner doesn't have thalassemia at all, meaning not even trait, you're going to specify not even trait, it means that there's no chance that they're going to have thalassemia because it takes two to tango. That's the way I like to think about it.
I like that. I love all your sayings and metaphors. They make everything really easy to understand. All right. This is another good one for my doctors out there. The only time spent on thalassemia care is on transfusion days. I think we all know that this is a big fat false. But what's really interesting is a recent study that shows people receiving regular transfusions spend on average, do you want to guess how many hours on transfusion-related activities?
I don't know, 8 maybe?
Ooh, that was close. 10.5.
Holy moly. So what I was thinking is like my patients being in my clinic, right? How long do they basically sit there the whole day?
Yeah. And you have to think about the outside things that happen. So let me read the statement one more time, and then we'll break it down. A recent study shows people receiving regular transfusions spend an average of 10.5 hours on transfusion-related activities on transfusion days and 1.5 hours per cycle transfusion-related activities on non-transfusion days. So we're also doing things on non-transfusion days. I know some folks get their blood drawn a day ahead of time. Whether you do that or not, like you said, you're spending practically an entire day getting the transfusion and all the processes that go before and after that. But also phone calls and making appointments, and think about travel time on top of all of that. This study is not even including the other time that we take for other tests like our MRIs and our endocrine and whatever else that we need to be keeping an eye on. So there's so much to it that I think we don't see with our eye and we don't think about. But our patients out there, I think we know how much goes into it. But I really want to focus in on it's a lot more than just sitting in the chair for the half a day.
Thank you, NinaMaria, for opening up my eyes as well to this. Maybe you can dive a little deeper and tell our audience in terms of the paperwork that you guys have to do.
Yeah, I really hate dealing with insurance. Not gonna lie. I guess there's a lot to it, right? There's making sure your tests and your things are getting covered. And sometimes, and your medicine too. And then it feels, at least in my experience, every few years, even if I have the same insurance, like something will happen where they're like, oh, we don't think we want to cover this anymore. And then I have to like go back and reprove that I need it. And I have to like have my doctor. And then that pulls you guys into it and takes time out of your day. Can you guys send like prior authorization? And then they go back and forth. And then it's like never ending. And then it's like, maybe I have to find another pharmacy to do it. Maybe who knows? And then, all the appointments. So spending time on phone calls. I know depending on like your work, if you need doctor's notes, things like that takes time to approve. I just feel like the list goes on.
And then also I think about that, at least in Canada, that often when we do MRIs, our patients get like the most ungodly hours, like at 2 a.m, right? So that means patients have to stay awake until then, go in, and that's a waste of a night. It blows your mind if you think about it, right? That you have to, just to do an MRI, you have to wake up at that time just to get it done. And then there goes your next day. You need to sleep.
I know. Okay, last one. Ready?
Someone who is non-transfusion dependent can become transfusion dependent. True or false? The answer here, surprisingly, is true. And the reason for that is a real tricky one. You want to tell us about the trickiness in this?
I just know it's tricky because it's something I was not familiar with until another Thal Pal of mine told me that he was originally non-transfusion dependent and later on in life became transfusion dependent. And I had no idea how that could happen or that it could happen, which is why I want you to explain how, because I still don't really understand.
Okay, sounds good. When we talk about transfusion dependent or non-transfusion dependent, is an operational definition. What that means is just a state at that time. If someone is dependent, needs regular transfusions in order to stave off a particular complication or complications, or simply to stay alive, as in those with thalassemia major, then that's classified as transfusion dependent. Many patients who are not being transfused for whatever reason. And I can tell you that when someone is not getting transfused, there's a lot of reasons that go into that. I can also tell you that many times I've seen patients who should be transfused are not being transfused. And so you can imagine that, again, being non-transfusion dependent is just a state. And if, say, someone develops complications later on, a prime example of that would be the extramedullary hematopoiesis that we just talked about, or if someone developed pulmonary hypertension, then obviously they will need transfusions to help them to reduce the complications that they're experiencing. Also, we have to keep in mind that when we transfuse someone, it really depends on the local resources. Different places have different resources in the world, and we have to balance between the need for transfusions, and there's lots of solid indicators or needs for transfusions, not being able to grow well during puberty, not achieving the potential, what was expected during growth, having really big spleen to a point where is patients constantly needing transfusions, or having these things called extramedullary hematopoiesis, to name a few indications here, or very symptomatic anemia. And then you've got to balance that against what is the availability of blood supply. If even in places where, there's readily blood supply, if a person has a lot of what we call antibodies that basically attacks other people's red cells, that limits the amount of blood that they can get, or types of blood that they can get. And also we have to think about access to iron chelators, because once you start on a road of regular transfusions, you're going to build up iron, and they're going to have some way of getting rid of the iron. Because if you don't get rid of iron, there's another set of complications you're going to deal with. So it's an operational definition.
So it sounds a lot like how folks who are maybe already transfusion dependent can fluctuate between having to go maybe every 2 weeks or 3 weeks versus 4 weeks. I know I used to do 3 weeks as a kid. Now I'm every 4 weeks. Is it in the same vein of that?
Yeah, so that's exactly. Yeah. So I would say that all those you just cited, I would classify those as transfusion dependent. Where you begin to say that you're not transfusion dependent is, I would say, is 6 transfusions a year. Anyone with less than 6 transfusions a year, usually you can call them not transfusion dependent, because they're spaced out so much that once you get a transfusion, if the next time you're getting is 8 or 9 weeks or even 10 weeks from that, you lost your effects from the transfusion.
Okay, interesting. So any of us really, we can fluctuate into what's needed. It's not a set in stone schedule, I guess you would say.
Exactly, yeah. The Thalassemia International Federation guideline certainly says that you need to aim for 9.5 to 10.5 grams per deciliter being the optimal transfusion. But again, you also have to balance out, how much symptoms are you having? Are you going for an operation later on, maybe in a couple of weeks? If that's the case, you'll need a couple more bags just to top it up. Or maybe you're traveling and you want to just top it up before you go. So a lot of discussion between the person with thalassemia and the healthcare provider.
Back to the theme of listening to the feelings and the symptoms versus the numbers. Circle back to that.
If I may do a plug as well, is that if you don't tell us, we don't know. We're not mind readers. So you have to be your own advocate. And I think you hit it right on the nail regarding that.
And that wraps up our 2-part series on myth busting here on Thal Pals, the Alpha Beta Revolution. We hope these conversations helped clear up some of the confusion and give you new ways to think about managing thalassemia, and maybe even busted a few myths you've heard before. Remember, staying informed and sharing your experiences makes our community stronger. Thanks for joining us. Until next time, take care and stay connected.